resulting in their relapse. As a country, we have seen a decline in the prevalence of malaria among children 6 months to 59 months. Looking at the data from 2011 to 2022, there's been a downward trend in all regions in the country. There's also a downward trend or a reduction in the inpatient malaria deaths, looking at the data from 2018 to 2022. So inpatient deaths have reduced in terms of the numbers from 428 to 151 as at 2022. And this achievement came about as a result of a lot of programs that have been put in place by the country and then other groups and the National Malaria Elimination Program, including the distribution of long-lasting insecticide nets, the indoor residual spraying, we have larvicidal activity spraying, and then the malaria vaccine, then the IPT that we give to the pregnant women, then the SMC, that's a seasonal malaria chemoprophylaxis, which are given to the SMC regions, of which Bunu is a part of it. And then there's always been constant retraining of prescribers and health workers on the case management, proper diagnosis, and proper treatment and follow-up for these cases. And I think that all these things have contributed to the reduction we are seeing in our prevalence and then mortality. This does not go alone, but coupled with procurement and supply chain that has been upped, and then the researches that are ongoing in the various research institutions across the country and among individual facilities, and then the advocacy that we continually do. However, I don't know whether as a country, we are not so interested in these gains that we are getting when we look at what is happening now with the global fund commodities that have been locked up at the ports. So we need to think about that. The case management guidelines over the years has seen some changes. And these changes came about, like Prof said, from the findings that we've been having from the institutions that have been doing these studies over the years. There's also incorporation of what we observe during the practice. We also look at the burden that we are having as a country, looking at the program goals and objectives, and then WHO recommendations that keep changing over the years. So all these come together to help us to be able to change our guidelines. There has been some major changes in the guidelines. One of them is the change of treatment of severe malaria from quinine to injection artesunate, which came about as a result of the findings from the Aquamat research, of which Confanochi was a part, or Ghana was part of the international countries that the study was being held in. There's also been the change from chloroquine to the ACTs, like Prof mentioned to us. But currently, with our current guidelines, which was launched in August 2023, we've been able to come about with certain changes. And as we go along this presentation, I would highlight some of the current changes to the guidelines. So making a diagnosis of malaria in children involves being able to take a very good history, performing a detailed and targeted physical examination, and requesting for the appropriate laboratory investigations to either confirm the malaria and also to look at some of the possible complications so that you'll be able to manage these children holistically. So for us to be able to take good history, we'll now look at the classification and the definition, so that as we take the history and examine, we'll be looking out for these things that will help us at the end of the day to classify our malaria as either uncomplicated malaria or severe malaria. So for uncomplicated malaria, is defined as the child who is presenting with fever or having a recent history of fever. And here fever per the age, the different age groups that we have, the definition changes. When you are looking at children who are less than 2 years, we are looking at a temperature the neonates, we are looking at a temperature which is less than 35.5 or greater than 37.5. And then from 2 years to 5 years, we are looking at a temperature of above 38.5. And then the adults, we are looking, older children and adults, we are looking at above 38.5, but we talk of hyperpyrexia when the temperature is greater than 40 degrees Celsius. For you to diagnose uncomplicated malaria, there should be no sign of severe disease, or there should be no evidence of vital organ dysfunction. And this fever should have a positive malaria diagnostic test, either with a malaria rapid diagnostic test or by microscopy. So for that, we will classify as uncomplicated malaria. For severe malaria, there should be fever with one or more evidence of severe disease, which we will talk about in our next slide, or evidence of vital organ dysfunction with a positive malaria test. When you diagnose uncomplicated malaria, there should be no delay in administering the treatment, as one of the treatment goals is to prevent progression to severe disease, because if it's not done on time, these children can progress to severe malaria. And the mortality without intervention for severe malaria is almost about 100%. So we'll look at some of the signs and symptoms or a sign of organ damage that we'll look for during the history, ask questions towards that, and during the examination, some of the things we need to look out for. For signs of severe disease, we employ the integrated management of neonatal and childhood illnesses, which gives us some signs for severe disease in any child who is presenting from 0 months to 15, from 2 months to 59 months. And these include inability to drink, a child who vomits everything, presence of convulsion or a history of convulsion, a child who presents with lethargy or generalized weakness or unconsciousness. And for the signs of vital organ dysfunction, for the brain, there are several things you could see: convulsions, unconsciousness, confusion, restlessness, lethargy. For the lungs, they may present with difficulty in breathing. They may present with deep breaths. They may present with signs of respiratory distress, fast breathing, intercostal recessions. For the heart, they may present with shock, and this shock would be compensated or uncompensated. So they may present with low BP, weak rapid pulse, cold extremities. Coupled with the fact that they are not able to feed, and the fact that the liver may be involved, may present with hypoglycemia. They may also present with jaundice. They may also present with decreased urine output. So it's important that as you are taking the history and you are examining, you are asking the mothers to find out whether there's been any change in that child's urine outputs during the illness. And then the color of the urine is also important, because when they present with dark colored urine, it gives you the suspicion that there could be hemoglobinuria. Then for the hematological system, they'll be looking at severe pallor, which may represent severe anemia. They may come with abnormal bleeding. The children may come with severe dehydration, hyperpyrexia. They may present with prostrations or generalized weakness. So as we take the history and examine, we should be looking out for any of these. And when any of these is present with fever and confirmed by an RDT or microscopy, you diagnose a severe disease or severe malaria in that child. For the severe malaria definition, certain lab parameters can also be used to help with the diagnosis. For severe anemia, clinically, I said you may see severe pallor. That's the child may present with paper white when you look under the eye and the palms or the soles. For the lab, you would get this child presenting with an HB of less than 5 grams per deciliter. Or the child may present with an HB between 5 to 7 grams per deciliter, but with signs of respiratory distress. You classify as severe anemia. The child may present with hypoglycemia. Technically, definition of less than 2.2, but in our pediatric population, we are looking at any RBS that is less than 3 millimole per liter. The child may present with acute kidney injury, and in terms of lab, you may see a rise in the blood urea. You may see the serum creatinine rising above 265 micromole per liter, or you may see a 1.5 fold increase in the baseline if it was done within 7 days. or an absolute increase of 26.5. With the jaundice, the serum bilirubin will be greater than 50 micromole per liter. They may present with metabolic acidosis, hyperlactemia, and then hypohemoglobinuria, which means that they may present with dark urine. You do the dipstick. The dipstick will show blood, but when you do microscopy, there will be no RBCs on the microscopy. And when a child is presenting malaria and you do the blood form and you are having a count of more than 500,000 parasites per microliter in those who are immune, then you say it's a sign of severe disease. But for the non-immune, we are looking at 100,000. Note that previously we were using 200 to 250 parasite counts per microliter, which has been changed to 500,000 per microliter. And with the respiratory distress, in investigating, you may see signs of pulmonary edema, which will be on an X-ray when ordered. So we'll look at the lab. How do we confirm malaria? We said that the confirmation can be done with both either the RDT or the microscopy. We'll take the microscopy. The microscopy is actually the gold standard, but because it takes some time to do, usually we go first with the malaria RDT because that is very quick. With the microscopy, usually it's a quantitative test and it's either reported as having parasites or no parasites. So currently we as lab scientists or biomedical scientists are supposed to report with the counts and then the speciation of the parasites that they are seeing, because from the thick and thin film, they'll be able to know whether the malaria parasites are present and the type of species that is there, which is going to influence the choice of treatment you give for these children. For the RDTs, it's very handy, very fast, can be used as a screening tool, but the limitation with that is that it can remain positive for up to 28 days even after treatment. And therefore, when you're interpreting it, you need to be cautious in a child who has already been treated with antimalarials for a positive test. It's a qualitative test and it's reported as either positive or negative. And either of these can be used to confirm a test. So we take a look at the RDT. When you do an RDT or microscopy and it's positive, what does it mean? We said that if there are no signs of severe disease or vital organ damage, you diagnose uncomplicated malaria in a person who has not taken any antimalarial drugs. And then if the test is negative, it means that the child's fever is presenting with, it's not likely to be malaria. So those of us who always think that every fever is malaria, we need to look at this very well. You need to investigate for other causes of fever or the illness that a child is presenting with. However, if you strongly suspect that this child's fever is attributed to malaria, then as you conduct a differential test with, you should do a differential test, meaning that if you did an RDT, you could do a microscopy to either confirm, because just one negative test doesn't rule out malaria. And then you repeat the test the following day and ask the patient to come back and check if that child has malaria or not. But if the test remains negative, it means that you need to look elsewhere for other causes of the child's fever. For the management of uncomplicated malaria, the treatment goals have already been outlined, but I'll just take them again. The first clinical objective for treating uncomplicated malaria is to cure the child as rapidly as possible, because you don't want the child to progress to severe disease, looking at the morbidity and the mortality associated with severe disease. And cure means that you have eliminated all forms of the parasite from the peripheral blood form. So you need to do the microscopy. Here you can't do the RDT. You need to do the microscopy to confirm that there are no parasites in the child's blood, and then you say you have cured the person. In terms of the public health objective, is to prevent transmission to other people, because if the female Anopheles mosquito takes a meal from you and picks up the gametocytes, it will transfer it to another person and thereby transmitting the infection to that child. So we want to prevent that with the treatment, and also to prevent the emergence and spread of resistance to the anti-malaria drugs, because we need to treat them well before the parasite actually gets wiser and then come in with all their bullets to resist the drugs. For the principles of management, these principles of management with the treatment of uncomplicated malaria is to use specific anti-malaria treatment with weight-based dosing, then supportive treatment, counseling, and follow-up. So for our first line treatment, we've learned this afternoon from Prof that our first line options are now 3. So we have the artesunate amodiaquine, artesunate lumefantrine, and then artesunate pyronidine. That is the addition to the first line. In our second line, we have the DHAP, that's the dihydroartemisinin-based piperacin combination. The dosages are there. For the sake of time, I will leave it so that we are able to go through when we get the slides. But artesunate amodiaquine can be given as a once daily or twice daily dose for 3 days. And it comes as fixed dose formulation, even though as a country nowadays, we don't have much of artesunate amodiaquine on the market for use. The other line is the artesunate lumefantrine, of which a lot of us here have experience with. It's given twice a day for 3 days, but let's note that the first 2 doses should be given 8 hours apart, and a total of 6 doses can be given. We need to note that taking these drugs with a fatty meal helps increase the absorption of the lumefantrine. So you could give a child something like a milk to help with the absorption of the lumefantrine so that you'll be able to clear. It also comes as fixed dosing. And the thing I would want to emphasize here is that unlike previously where we were stuck with treating malaria in children who presented and were less than 5 kg or less than 6 months, now studies have shown that we can give them the AL at the same dose as a child who is 5 kg or 6 months above.
Dr.
For the dihydroartemisinin, yes?
We should be running up, please. Your time is getting close. Yeah.
Oh, okay. Well, I'll be running up very soon. So for the treatment failure, I think Prof took us through it, so I wouldn't waste much time on that. But what is known is that if somebody comes with a true treatment failure, that's you've ruled out vomiting and other things, you give the alternate first line. So if you gave artesunate amodiaquine, you give artesunate lumefantrine, or you proceed to a second line anti-malaria or ACT. We've talked about reinfection, so I wouldn't waste much time there. But for those who the speciation shows that they have the P. vivus or the ovale, in addition to the ACT, we may have to add primaquine, and the dosage is dependent on the GSSPD status of the person. So we'll look at management of severe disease or severe malaria. For the management of severe malaria, the first thing we need to do is resuscitation. We need to assess these patients who are coming, because the complications that they may be bringing may be life-threatening and can kill them even before we start the specific anti-malaria drugs. And then we need to actually focus also on the supportive care we give them, and then counseling, and we need to promptly and appropriately refer them if at our level we are not able to manage them. So for the initial assessment, we use the ABCD approach, looking at the airway, breathing, circulation. The slides will be given so that we can look at it. For the minimum labs to do when a patient is suspected to have severe malaria, if you are at the health center or you are at the district level with not much logistics when it comes to lab, you can do the HB, you can do a urine dipstick, the random blood sugar, the blood form for MPs, and then at a higher level, they may be able to do the full blood count, they may be able to do the blood urea creatinine, electrolytes, liver function test, but these are not something you just request. It's based on the presentation that the patients present with and the other differential diagnosis that you have. It's worth to note that do not delay treatments when you suspect severe disease. You could start the parenteral anti-malaria immediately you suspect severe disease, because with severe disease, usually they don't have high parasitemia, and therefore you may get the initial RDT to be negative or even the microscopy to be negative. However, you can repeat at 12 hours and 24 hours just to be double sure that it is severe malaria you are dealing with. After 24 hours, if the test is negative, it means that you need to look for other causes of the child's presentation. In terms of preference, IV artesunate is the preferred when it comes to the management of severe disease. And for severe disease, parenteral antimalarials must be given, and it should be done for at least 24 hours before you switch over to the recommended ACT for also 3 days. For those at the CHIPS and the health center, it's advised that you give a pre-referral treatment if it's there. The preferred is IM artesunate, but I know that some CHIPS and health centers have been stocked with the rectal artesunate, which can be given at 10 milligrams per kg, and then for children under 6 years only, and then referred to the appropriate center. This table looks at the various complications of severe disease and what can be done. So when we get the slides, we can go through it, or when there's questions, we'll go through that. This is a chart showing how we manage them when they come with seizures, because being a part of the malaria audit team, and especially for children, this is an area that we have a challenge, especially when the children are coming in with seizures. So this will be very helpful to us in places. It's important that we monitor these children vitals as they are on admission when they come with a severe disease, which can be done hourly to 4 hourly, depending on the child's presentation. We need to monitor their blood glucose level, monitor their level of consciousness, especially in cerebral malaria cases. Look at their input and output, monitor them for further seizures, and also review their parasitemia, especially in children who are not responding to the antimalarials that we have given. To take a look at some of the long-term complications of malaria, it could present with CNS impairments, especially for the cerebral malaria. You could have late onset anemia, especially when we use artesunates as for combination as a treatment. And then there could be recurrence. They could present with nephrotic syndrome, especially for P. malariae, and they may also present with the hyperactive malaria disease. These are my references. My special thanks go to the program manager for the National Malaria Elimination Program. Thank you very much. I have other resources, which when you get to the slides, we could look at. So thank you very much. And then my last word for today is that as we celebrate the National Malaria Day, let's all accelerate the efforts to fight to eliminate malaria in Africa with equity. Thank you so much.
Thank you very much, Dr. Rosemond Kuku. You've done very well. Just take a sip of water, and then we would need to make room for. Is there any pressing question? You can raise your hand and ask. And you have opportunity to also put it in the chat box, because we need to really move on to the next presentation. But yes, so Nanam Reku Jima, you can go ahead. You can ask your question, and then we'll take the next presentation. The others can put it in the chat box. We want to get all the presentations, and then we can have a group discussion after that. So go ahead and ask your question, please. Unmute. Sorry, can you unmute, please? The support staff, can you just check that are there challenges with some people unmuting?
Hello.
Yes.
Boss, please, good afternoon.
Good afternoon.
Please, I'm Ahin Emmanuel, a physician assistant.
Okay.
Please, I've realized something that's going on in our practice. I realized that sometimes FBC is negative, RBT is negative, but when the platelets count is low, it's being considered as a malaria positive person, we treat as such, and the person gets better. So I wanted doctor to talk about that if she has come across by the low platelet treatment.
Okay. Dr. Kukru, it's over to you.
Okay, thank you very much. So in my reading or looking at the current guidelines we have, there's nothing on treating malaria on the suspicion of just thrombocytopenia. Even though we know that malaria, through the mechanism by which it causes severe disease, that's the rosetting, the cytoadhesions, it can clamp the platelets and result in thrombocytopenia, and that's why they are at increased risks of bleeding. But the other causes of thrombocytopenia, so like we said, if it's a child presenting with a severe disease or signs of vital organ damage, we say start and then repeat the test for the malaria at 12 hours and 24 hours. If it's negative, then it means that it's not malaria, because now we don't do presumptive management of malaria again, but we actually go with a 3T policy, which is the test, treat, and track. So just basing your diagnosis on thrombocytopenia, in my opinion, it's not done per our guidelines. Thank you.
Yeah,
But Dr. Nemo, you can help me with that.
Okay. I just want to, the host, the Society of Ghana, I don't know who is sitting by as the host. Please check and make sure that people who want to talk are unmuted so that they can, I'm sure some are having challenges with unmuting. So please take notes. In the meanwhile, if you're having challenges with unmuting, just type your question into the chat box. Dr. Koko would take the questions and type in the questions or response in the chat box as we make room for the next presenter. But is there a comment from Pediatric Society?
Dr. Onumel, sorry. Should we unmute once they raise their hands, or you would call first?
I find it difficult to even, okay, now I can see. So I can see Kingsley Tete's hands up. Kingsley, can you?
Okay.
Yeah,
okay, so go ahead. But we need to, so I will give you the chance. We are almost going into the next presenter's time. I would give you the chance, and then the others, either you chat in the chat box, or I just want us to finish all the presentations and then give room for more questions all up. So just be done with your question and we move on.
Okay, boss. So, boss, please, this one is just a quick one. Doc, thank you very much for the presentation. I want to ask, there is this practice of, the resource limited zones. So, if I don't even have the kit to do an RDT for malaria, but I'm suspecting, we have this practice of you give a start dose based on the weight per kg that you've calculated, and then you give a start dose and you take the sample to where the test can be done. Then when your result come and maybe it's negative, then you stop. Or you don't continue the treatment. I just want to ask if this practice can go on, since we are trying to, Prof had the first presentation, he spoke about the resistance. Since we are trying to fight it, so is it a practice that we can continue, or is something that we would have to desist from until we have the labs? Thank you.
Thank you. Dr. Animal, please, can I answer?
Yes, go ahead.
Okay, so thank you very much. I don't know which type of classification of malaria you are talking about, but for those who don't have any sign of severe disease, it's not advisable to give a start dose. If they come and you will not be able to test, you ask them to do the test before you start the anti-malaria treatment. The only exception comes in when they come with signs of severe disease or vital organ damage. Then that is when, because of the mortality associated with those ones, then you could start whilst you do the test. But for uncomplicated malaria, you always need to test before you treat. Thank you.
Thank you very much. I'm also taking notes. In the meanwhile, Rosemond, can you stop sharing? And then let's get to the next presenter to share his slides as I do the introduction. And the next presenter is Dr. Pham Emmanuel Berfi Boateng from Novartis. And he is going to talk on malaria in infants, exploring existing needs. Let's bear in mind that the sponsors for this program are Novartis, and this is their rep speaking, but he's going to do justice to malaria in infants. Importantly, he's been with Novartis for over 11 years as the medical advisor, specialty medicines and programs for Anglophone West Africa. From January 2023 to present, he has held positions as the medical advisor, as I said, a senior medical rep for over 6 years, and he's won several awards, including Best Medical Rep in the days of GlaxoSmithKline, Novartis Customer Solution Model, and others. In the interest of time, let's invite pharmacist, Dr. Pharmacist Befi Boating to give us the presentation. Thank you. Meanwhile, you can type your questions into the chat box. Dr. Kukuru will respond directly to them, and I would also do some response along, especially the ones that she created. Thank you. So over to you, Befi.
Yeah. Thank you so much, Dr. Enimel. And just to confirm if everybody can hear me.
Yes, you are very clear.
And my slides are as well visible.
Yes, it is.
Great. Thank you so much. And so the introduction has been provided. And unfortunately, I'll not be talking as a medical rep as I used to do in the past, but more or less, highlighting some of the challenges in the management of infants when it comes to malaria, and maybe buttress or as well underscore some of the points raised by Prof. and then Dr. Kukro in their respective presentations.
As a quick note, you have 3 minutes. Doc, you have 3 minutes.
In fact, I might finish before you'd have your shortest presentation with mine. So I don't think I need another 15 minutes. All right. So to go on with the presentation, let me provide this disclaimer that I may, in the course of the presentation, mention a number of situations or solutions that are yet to get regulatory approval. And if in the course of the presentation or in the discussions that ensue thereafter, if any solution of Novartis come out for discussion, it is appropriate that you refer to the appropriate packaging set, to get the right information to manage those solutions. So one of the things that is done on all of us is the fact that malaria is disproportionately, the burden of the disease is disproportionately heavy on infants, and to the extent that 80% of the mortalities are those under 5 years of age. It's very significant, and it's also the reason why Novartis, and personally myself, I'm happy to be on board with this CME, because pediatricians come into sharp focus when we want to deal with malaria in this particular segment of patients, and so I'm happy to come on board with this program. Now, in the course of the presentations that I've had, while we capture the broad category of patients from 0 to 5 years, and there are a number of challenges that arise, particularly for those who are around the young infants, those from 0 to 3 months, and even up to 6 months when it comes to the management of uncomplicated malaria, especially, in this regard. And what is also poignant to mention is the fact that the data for malaria, uncomplicated malaria in this patient segment is largely unclear. And I'll demonstrate that with the next set of slides, because there's inconsistency in the measurements that has been done, with the studies that we have available, and in some of the descriptions, the inclusion and exclusion criteria are not consistent. And so the numbers, are not very clear for us to characterize really the burden of this disease in those patient segments. And as I indicated, if you look at this map where we have, many parts of the world that come into focus when we are talking about malaria, as I indicated, the data is all over the place. It's not consistent because of the reasons that I mentioned earlier. One other element about the management of malaria in those patient groups is the understanding that we have, or the science that we have, that mothers would pass on some protection to children in those age categories when they are born. And so there's a less likelihood of them coming down with malaria. We also know that fetal hemoglobin confers some protection from the development of malaria. And also the fact that breastfeeding in itself also protects infants in that category from malaria. And so, all these knowledge that we have more or less as well maybe reduces our index of suspicion when we have a patient with a febrile disease presenting for care. I had a conversation with a resident, and what I was made to understand is that if you had a febrile condition for a child in that or an infant in that age category, if you had malaria as one of your differentials, you are likely to repeat the rotation and so on and so forth. And I've had, similar conversations even outside Ghana where this has come up. And so somehow this, patient segments do not come into a lot of focus when malaria conversations are being had. One other element about it is that even when such patients develop malaria or come down with malaria, of course, the symptoms are not specific, and so it's easy to have your diagnostic maneuvers all over the place, because many other conditions also present similarly as regards febrile conditions. Then as well, there's low parasitemia that is possible in young infants when they have malaria, and so it is very, very easy to misdiagnose and overlook, the presence of malaria in such patients. And so these other elements, as I indicated, makes it very challenging, in managing patients in that category. Now, when we have succeeded in even diagnosing well or correctly the presence of malaria in patients under 5 kilograms, while there's a strong recommendation to use the ACTs as Dr. Kuku mentioned in her presentation and supported by the WHO guidelines, it is also important to underscore the fact that the recommendation is not really supported by the grid framework, where there's a lot of data, that backs this recommendation. And the challenges around that is the fact that there's limited studies that have been done in patients in those categories. And what I hear pediatricians say all the time is that a child is not a miniature adult. There's so many things that happen, the pharmacokinetic and pharmacodynamic interaction of the drug and the patient, that we need to characterize well in those patient groups. That data may not be available for. And so while there's a strong recommendation for the use of ACTs in those patient groups, we are not really sure what the outcomes are, and so on and so forth. And on account of that limited knowledge or limited data in that patient segment, we are either underdosing or overdosing. Then the other challenge is even the formulation that we have of the ACTs that we are supposed to use. Is it ones that make it easy to administer to a patient in that category? The proportions of the component in the ACT appropriate? Do we have optimized, treatment for such patient groups? And that is another gap that remains, and it's one of the things that Novartis is happy and willing to work with the Pediatric Society of Ghana individually and as a corporate body, in trying to characterize well, those patients in that category with research, with solutions, and with guidelines that we all can as well improve the knowledge in that space and also the care that is available for such patients. So that would be my conversation for today. And just to summarize that, the management of malaria in such patient categories is challenging. And when recognizing the diagnostic tools and managing such patients, even though the tools are available in terms of medications, it's still challenging because we do not have optimized care for patients in those categories. And that is why Novartis is happy to work with everybody here on the call, in improving and making sure that patients at the end of the day, get the best of outcomes, and we change the narrative as regards the burden of this disease, particularly for us in this average. So that'll be my conversation for today. And it's an ongoing conversation that I'll be meeting, key members of the society, in what lies ahead with this kind of objective. Thank you very much, Dr. Edmel, and your team.
Yeah, thank you so much, MD Befi Watson. We are grateful for saving us some time for more discussion. But this is an important area, and I'm happy you are coming up with proposals challenging pediatric society to take up essential research questions in this critical age group. And I know pediatric society is keen, has a lot of research experts looking at diverse areas. And this is an area we can come together as experts in various fields and get epidemiologist perspective, clinical perspective, the pharmacy component. And I'm sure we can sit down as a society with you, draft a good proposal. We also need a lot of topics for our fellows in training, and therefore it's an opportunity. So I'm also sensitizing our senior residents who are on the call. There's opportunity for some support if we want to define the challenges in infants with malaria. And there are so many areas perspective we can bring on board. Let's get our mentors on board to help us shape the concept and be able to really answer such questions, which, as we've said, Novartis is interested in partnering us to achieve that goal. So let's make room for one or two questions before we go to the final presenter. And I would wish that we are snappy with our questions, get the last presentation, and then have the rest of the time to really have a thorough discussion from all perspectives. So the floor is open. Is there any questions for either from previously, Rosemond, from our first presenter, and Dr. Befi, before we go to the last presenter? Kingsley Tete, is it a new hand or the old one?
Boss, please, it's a new hand. I'll come back.
Okay. So that's your question.
Yes, boss. Boss, I want to thank the presenter a lot for the presentation. Yeah, it was very brief and concise. Please, I wanted to know, so the management at the different levels. So when you come to the peripheral facilities, the children, sometimes it's so difficult getting in a line for them. So that if you could start your IV artesunate, you could start before even the referral. Boss, please, these challenges we've been having, especially where you don't even have a phlebotomist, not to speak of when you can't get the line, there's nothing you can do. Boss, I wanted to know, are there other vias of administration, other ways where we can be able to safely deliver some artesunate before we refer the cases? Thank you.
Yeah. Thank you so much for the question, but I believe this question will be best responded to Dr. Akoko, as she handled the management bit.
Yes.
Hello.
Respond. Yeah, go ahead and respond.
Okay. So I also work in the district, so sometimes I'm much privy to the challenges that we have, especially from the health centers and then the chiefs and artesunates IV is the preferred when it comes to severe disease. However, there are other options you could consider when you are not getting it. And I think from my reading, artesunates can also be given as IM, but the preparation may differ when you are given it IV. When you give it IV from the IM. Also, you could do rectal artesunates. And I know that some health centers have been giving the rectal artesunates. But I don't know whether they too are like those drugs are also expired, because you know that majority of the times we are given a lot of drugs which are almost nearing expiry, and when they come as donations, and then we are not able to make good use of it. So I'm yet to know whether they still have these ones, but you could do that. Even if you don't have artesunate, you could do artemether, IM artemether, or you could still do either IM quinine or IV quinine. So all these are options. For the sake of time, that's why I wasn't able to go through the various peripheral treatments that could be done before the child is transferred to the next level.
Thank you very much, boss. Thank you very much.
So I just add a little to what Usman has said. Yes, this is on the ground practical experience. And yes, in real life it happens. The reality is there are options, but I would believe that you are not a one-man expert. Thanks to technology in your district, or like you may have a contact of someone who is probably a senior person or even a colleague who has a bit of experience. So let's share some of these challenges instantly and get options, because yes, if IV is not possible and IM is an alternative, you probably may not have a skill, or you just may not immediately have the skill, but this thing can easily be either hold up or just on a call description on what you need to do in doing the RAS mixing, so that if you give it IM instead, it doesn't cause problems or abscesses or adverse events for the child. So there's a need for talking to each other and then come up with opinions that would help as you make plans to send to the next level. But definitely action should be taken from your point before the patient moves on to the next level, as practical as possible. Is there any other question? So let's take the last presentation. It's also going to be, we are getting, so can you unshare and then let's share the slides for the last but not the least presenter. And by way of introduction, we are going to Jeffrey Adam Upper, who works with National Malaria Elimination Program. And since January 2001, he has been working with the National Malaria Elimination Program as specialist pharmacist, public health, head of units and focal person for procurement and supply chain management. I'm sure some of the burning questions with supply you would help us answer. He's registered with the Pharmacy Council and a member of the Pharmaceutical Society of Ghana. Over to you. Doc.
Thank you very much, moderator, and thanks to the Pediatric Society for the opportunity. I just want us to go through our elimination strategic plan, some key concepts, and what we hope to achieve. Sorry, my screen is frozen. All right, so this is my outline. Fortunately for me, Dr. Kukru has gone through most of these things, the background, the prevalence, and all the stuff. So I won't waste much time so that we can look at the main thing. So what's the rationale for malaria elimination? If you look at malaria control, we are just focusing on burden reduction. And then we're looking at preventing vector and man contact. And by that, we're mainly focusing on larvicidin. We're looking at other interventions like indoor residual spraying that kills the mosquito. But when you're looking at elimination, we want to interrupt transmission and then ensure that within the locality, there is zero locally acquired cases. So if you find anybody within that locality with malaria, then it's not local transmission. Probably it came from outside that zone. And then as much as possible, we prevent reestablishment of transmission. So in essence, we're looking more at enhancing resources. We need to innovate targeted interventions, and another key thing, political will and community orientation and involvement of everybody on board so as to be able to achieve the elimination target that we set for ourselves. Dr. Kuko showed some of the data, so I won't really bother much about it. But if you look at the line here, that's our testing rate from 2019 to 2023. You can see that we're doing so much in terms of testing. If you look at the bar charts quickly going through, the blue line are suspected cases. Suspected cases over the years have been around 12 million. And then if you look at here, these ones are that orange bar or whatever, that is more of the tested cases. And look at the tested cases, the ash one gives you those that are confirmed. So we realize that for most of the tests that are done, confirmed malaria cases just hovering around 6 million over the years. That it keeps dropping a bit here and there. One key concern for us as program level is between the ash and then the yellow. The yellow is those that are tested, confirmed cases that are put on ACT. There is that gap there, and that is one of the things that we want to unravel. Because once you test and it's positive, the patient has to be treated. And that's one of the gaps that we're looking at. If you're looking at malaria deaths per 100,000 population over the period 2019 to 2023, you can see a downward trend from 1.05 in 2019 to 0.43 in 2023. Case fatality rate. So, as Dr. Kuko said, the most vulnerable group, we're looking at children under 5. Right? And if you're looking at case fatality among this group over the years, there was downward trend until 2022. Last year, there's a slight dip from 0.05 to 0.06. But overall, if you're looking at malaria case fatality, both average for both under 5 and above 5, the trend, they maintain the same trend from 2022 to 2023. But generally, you can see that from where we started from, there's been downward trend. And then this just case fatality, comparing the various regions. So for last year, the major concern is with Northeast, that's quite high. So we have Northeast, we have Bono East, and then a bit of Volta. I was trying to look at these ones, but on the average, there's generally downward trend when you look at the national average. Right. Dr. Kuko also talked about this one. So now the prevalence, average parasite prevalence in the country is about 8.6, although there are varied prevalence rates across the various regions. She spoke about it, so I'll skip that. So why are we talking about the elimination? During the 2022 World Malaria Day commemoration, there was that unanimous call that, we have seen downward trends in almost all the indicators. So what prevents us from doing something new, innovating, getting new interventions here and there that will hasten that step towards elimination and not just fall on, okay, the burden we are reducing, so let's just continue as it is. We need a paradigm shift and then look at how we can fast track the successes that we have chopped, to even get better outcomes. And that call led to a series of activities, all aimed at malaria elimination. So there was a malaria think tank meeting made up of experts that used the WHO documents, which we call MEAT, Malaria Elimination Assessment Tool. And that looked at what we have achieved as a country, where we are, and then to tell whether we'll be able to make further progress. There was also a midterm review, but we're having strategic plan that's supposed to end in 2025. So there was a midterm in 2023 where we looked at what we set out in the strategic plan, what we have achieved, what have been the challenges. And based on the MEAT assessments by a think tank group, and then the midterm review, we developed a new policy, a new strategic plan that is supposed to lead us into elimination. the elimination that we are talking about is not complete elimination, like the whole country at a go, but it is subnational. So we termed it progressive subnational elimination. We have, if you look at the map here, we have there was an assessment that looked at parasite prevalence, that looked at incident of cases, other demographic factors that were put into a model. And then that model gave us what we have on the left here, where I have here. So if you're looking at this, there are four zones. We have this orange patches, we have this yellow, and we have the green, and then the light blue. The light blue is very low ecological zones. These very low, we have about 21 districts in Greater Accra, and then Kumasi Metro, some few districts in there. And then we have the low ecological zones. For low transmission zone, we have the rest of Greater Accra and some few patches here and there. And then we have the moderate, and then the high and the very high. Now, in going into the elimination, and because if you are deploying any intervention, you will have to put in place so many factors. So you may not want to do within the same districts, the same region, one district, and leave the others. So we really had to put all of them together for implementation purpose. So now basically have 4 zones, the very low and the low, we're looking at them together. And then we have the moderate, and then we have the high. So for now, our elimination agenda is mainly targeted towards the very low districts. And these very low districts are mainly in Greater Accra. What are the goals that we've set out for? So we are hoping that by 2028, we would have reduced malaria mortality by 90% using the 2022 baseline. So what I showed earlier, we're hoping that we'll go down further. This is for the whole nation. We also hope to reduce malaria case incidence by 50%, also by 2028. And then with the 21 districts that are in very low ecological zones, that as I showed earlier, we're hoping that we will achieve malaria elimination. So what are the objectives? What are the strategies that we hope to deploy? One, we're hoping that everybody in Ghana have adequate knowledge, attitude, and practice towards. Sorry, just a minute, let me screen. Something is blocking. All right. Yeah, so we want to ensure 100% of population have adequate knowledge, attitude, practices, and requisite skill for malaria elimination by 2028. And so we're going to do more of community engagement. We need to develop new social and behavioral change tools that will really hammer down the message onto the people. And then we also want to ensure that everybody in Ghana use at least one malaria preventive measure. We are looking at new interventions. We are looking at expanding some of the interventions that are already in existence, and then also improving delivery so that access to any of the interventions, preventive measures that are available will not be a challenge to anybody in Ghana. So if nothing at all, whether IRS, whether long-lasting insecticide nets, whether SMC was prevent, so any of the preventive measures, we want to make sure that at least everybody in Ghana has access to one of them. We want to ensure that 100% of suspected cases are tested. As we looked at the performance from last year, it's about 98%. We're hoping that by 2028, every suspected malaria case is tested to be sure that indeed it is malaria before treatment is provided. We also want to ensure that all the confirmed cases are appropriately and effectively treated. by 2028. So that gap that we see there, where you have diagnosed as malaria and there's no treatment corresponding, we want to make sure that that is addressed. We also want to improve surveillance and monitoring, and not just even surveillance. We want to make sure that at the sub-regional level, at all levels, once you follow up on these malaria, the reporting, the monitoring activity, everything, all the results, you're able to analyze them at your local level, see the trends, what's happening, and what key interventions that need to be put in place. We're also looking at extending even our surveillance to the community pharmacies, the over-the-counter medicine sellers. We know if you look at our database, most of them are from public facilities and a few private hospitals that report into DIMS. Now we want to really get to the pharmacists and OTCMS, assist them to report on malaria cases. We want to equip them to be able to test and then also report, so that we have a better picture of what is happening across the country. We also want to ensure that malaria commodities are available. And Dr. Kukro mentioned the challenge that we have with some clearance at the port, but it's been addressed. We're hoping that this one-off thing, we're hoping that it will not be recurring. And going into elimination, it is important that commodities are readily available, so that we wouldn't have to do trying, as one participant was asking. The policy is that you test before you treat. And until recently, we had enough RDTs in the system. So we'll make sure that whatever that is in the system is moved around, so that every facility, whether urban area, rural area, whatever, once there's access to care, we should be able to test. We'll have the commodities to test and to treat. So we'll make sure that we work on that. We also want to improve governance and then program management. We need a lot of political commitment and then stakeholder engagement. When you're talking about elimination, it is no more Ministry of Health affair. It is the whole nation. So if it has to do with the borders, immigration officers at the borders, what are they doing? If we're looking at community, the local governance, if we're looking at education, so it's a broad stakeholder involvement when it comes to elimination. It's not just about Ministry of Health or Ghana Health Service or teaching hospitals. It is every sector has to be on board. And then another key thing is to improve mobilization of resource, which is very key, because most of the interventions will require resources that currently are not available. So we need to mobilize new resources, and then also efficiently use resources that are available. So the very little that we have now, we need to make sure that we've used them judiciously to be able to achieve the interventions that we need. So we'll be calling on our private sectors to support us, apart from our partners, regular partners that support malaria program. So these are some of the interventions that going into elimination we're still looking at. So for all districts and all zones, we'll still continue with IPTP, intermittent preventive treatment of malaria and pregnancy. We'll continue to make sure that anti-malaria commodities, RDTs, ACTs, injectable artesunates, and the new ones that are coming, they are all made available. We also ensure that they are used appropriately. We'll continue with the distribution of long-lasting insecticide nets. So currently we have started point mass distribution. We'll continue with it. The school distribution of nets will continue, and then giving of nets to pregnant women at ANC and then postnatal clinic will also continue. We do a larval source management in the district. That will also continue. And then we'll continue with our SBC activities. We've been enhanced it so that behaviors that are not helping us to achieve the target, we'll be able to address them. Entomological and epidemiological surveillance, monitoring, evaluation will continue. We'll continue with research, because that informs us as to the next steps and able to assess what how effective what we have is helping. So we'll look at research, we'll continue. And then leadership and management at all levels is also key. Case management, quality case management, as Dr. Kukro took us through, we want to make sure that there's quality and effective case management at the facility. Once the person has malaria, how is the person managed? So look at that. And then we'll be introducing post-discharge malaria chemo prevention, which is a new one, where we'll give at regular intervals long-acting anti-malarials to children who are admitted for severe malaria with severe anemia. So once they are discharged at fixed intervals, we give them long-acting anti-malaria. And then the malaria vaccination, there's going to be expansion from the initial few districts that were implementing them. For the moderate to high burden district zones, we're hoping to expand the indoor residual spraying. And then for seasonal malaria chemo prevention, which currently we're doing in 7 regions, Upper East, Upper West, Northern, Savannah, Northeast, Bono East, part of Bono East, and then Oti. We're hoping that will expand to other districts which falls into those categories. Once you meet the category, once you meet the specifications, we will look at that. And then we also want to we'll be introducing intermittent preventive treatment of malaria in school children, IPTHC, in the moderate to high burden districts. For the low burden districts, we want to enhance N2 and EPID surveillance, to there be more of active case detection and response. And then for the very low burden districts, the 21 that we've targeted for elimination, apart from the enhanced N2 and EPID surveillance, we also we'll be introducing mass drug administration, which we hopefully, probably this year, we'll do the trial, and then we'll see how we scale up to all the 21 districts. And then there's also the introduction of single low primaquine administration in the low burden. So we want to make sure that for if you come with uncomplicated malaria and you are giving ACT, you have a single low dose of primaquine added to the first dose. And this is aimed at clearing the liver stage of the parasites so that you won't transmit it. You get clear, you'll be treated all right, but you want to make sure that you don't transmit the gametocytes to other people in the community. So what are the roles that we're expecting? As I said, going into elimination, it is beyond Ministry of Health. So we need all stakeholders to be on board. So for political leadership, we need commitment from government. We have to form intersectoral malaria elimination committee with leadership at the peak of government to drive the elimination agenda. So if you have, let's say, the chief of staff who is chairing that committee, then he has that authority. So if Ministry of Health, the Ministry of Local Government have to do something, be able to bring everybody on board and be able to champion that cause. We need the chiefs, the assembly members, and then the local community, so they need to own the interventions and then also commit resources, because it's partnership. We need them to also commit resources towards whatever intervention that is being implemented in their areas. And as I said, all sectors, so ministries, departments, and agencies, we need to partner each other and see commitment from everybody, to be able to realize what needs to be done. Especially if we come to the local areas, if we have to do lava source management, if we have to implement bylaws, good health practices, the district chief executives, the assembly members, and everybody to be on board to enact those bylaws and also implement them. we need community members, we need the media, we need the private sector, especially when it comes to funding. We need them. Academic and research, we still need to research, do more research, see what's happening, and then develop new strategies, update our guidelines, protocols, to be able to achieve the outcomes that is needed. For health workers, as Hugo said, for us, the key thing is prompt diagnosis and treatment of cases that come, adherence to the case management guidelines, the 3T policy, making sure that we properly track all our cases and then report on them. For community levels, we need.
Please be rounding up for us.
All right, yeah, I'm almost at the end. Yeah. So for the community level, we need sensitization of members to own and promote proper use and uptake of the various interventions. So IPTP uptake, use of LNIs, we expect our NGOs who are in these communities to steer these activities so that we'll achieve the needed outcome. So when I share the slides, our strategic plan is available. It's quite a bulky document with all the key things in there. The link is provided. Once you click the link, you'll be able to have the soft copy available. Malaria elimination is possible with more focus. Together, once we work, I'm sure we'll be able to get malaria out of Ghana, and Ghana will be malaria free. Thank you very much.
Thank you very much, Jeffrey, for the great presentation. It's been almost 2 hours of rollicking with malaria information. It's important to take note of these few announcements before I open the floor for some few more questions. Quite a number of answers have been provided in the chat box already. Pediatric Society has plans to share the slides, and I will give Gabby a chance to tell us how so that people get assurance. This is CPD accredited. I'm not sure of the number of points, but I'm sure Gabby would address that. Let me acknowledge those who are on YouTube. We got in excess of 500 and some are actively on YouTube, but most of you have sat through over the last 2 hours. Very great on all our part, and we really have refreshed our knowledge on malaria. Let me make room for any pressing questions if there are, because I know quite a number of the answers have been provided. It's a minute past 5 o'clock already, and we don't really want to go past 5 minutes or 10 minutes past 5. But Gabby, can you respond to how the presentations will be made available to those who joined? And then if you have an idea of the CPD points, people are asking how many CPD points, but I'll leave that to you. Gabby, if you are there. Or for that matter, any executive who is happy to speak on behalf of Pediatric Society.
Yes, Dr. Animel, thank you. This is Dr. Opon, Vice President, PSG. Yes, once we have approval from our facilitators, the slides will be made available through various platforms, WhatsApp, and then the society's website. So we'll link up with members through the same platform that we use to disseminate this CME program. The CPD points, we are still waiting for confirmation from the MDC. So as soon as we do that, we will upload them on the various platforms. Thank you, everyone.
Yes, sorry, I couldn't unmute. So we will send the slides via email. We have everybody's email because that's how we registered. So we will send the slides via email to all our participants. But then the YouTube channel is always going to be available for members to rewatch the event. So we can as well use that route.
Okay, so I see 2 hands up. Caesar Lirasi, can you unmute and start talking?
Okay, good evening. Thank you very much for the presentation. My question is with regards to the interventions, the various interventions outlined. I wanted to find out, do they always do an evaluation of the impact of some of the interventions? Because, for instance, when you take the indoor residual spraying, it's usually done by Agamal. Last year, for instance, they came to my community and they did the spraying to most of the, even almost all the the houses. But then when you look at the data, we realize that we still had a lot of cases, even more than the previous year. So I really don't know if they always make an evaluation of the impact of some of the interventions. That's my question to him. Thank you.
Okay, so take note of the question, Jeffrey. The second, Shaibu Seidu, please ask your question so that we take both at the same time.
All right. Thank you very, very much. It's a very wonderful presentation and very insightful. My question is a little bit, political in nature. With our recent stock out of RDTs and other malaria commodities, which are very, very important to our elimination drive. We ran out of this. For us, we did everything possible. We managed our stocks. We're trying to request on time and all that. But unfortunately, the shortage was at the port. The commodities were in and they were at the port and they were locked up at the port. So I would like to find out what happened. And then what are we doing to prevent it from ever happening again?
Okay,
that's my question.
Now let's take the last hand, Muniru Nuruddin, yes, and then we can respond to the Nuruddin, please. Can you unmute and make your point? Okay, Jeffrey, start responding, and if you're able to unmute, then we can hear.
Okay, all right. So thank you for your question. On the impact assessment of indoor residual spraying, yes, it's been done. It's been done. And as I said, we're doing there are a lot of surveillance activities ongoing. So we're trying to find out, especially if you pick Upper West that is purely doing IRS, and we still have a lot of cases. We do SMC and other stuff. So there are a lot of assessment ongoing currently to see the impact of these interventions and what factors are contributing to those high cases. So, for instance, in the IRS areas, we're looking at the characteristics of the Anopheles, the species available. Are they resting indoors? Are they doing more outdoor biting? Because if they are doing more outdoor biting, then it means that you will even get the parasite in your system before you go to the room to sleep. So there are a lot of impact assessments that are done yearly, and there are new ones that have been initiated this year to better understand what is happening. And these always inform which intervention to amend, to change, or to cancel. So there are a lot of impact assessment. With the issue of stockouts, well, it's an issue that is beyond us. We did everything to have commodities at the port since, I guess, last year. One or two circumstances came up. I mean, we have learned lessons from them. We're hoping that with the elimination agenda ahead of us, we'll be able to address it. One of the key things that we're also doing is providing microscopes for most facilities, health centers, so that in the absence of RDTs, where there's a bit of challenge, I mean, if you have the gold standard and you have the skilled personnel to be able to handle them, we'll be able to address them. But we'll work at preventing some of these incidents that have resulted in stockouts across the country. Thank you.
Okay, so please, there's no need for you to share your email. Rather, fill the evaluation form. If you registered, Pediatric Society has your email because there was a link that sent to you. And then they are sharing the slides with us through your email. So you don't need to put your email in the chat box. Okay, so Nuruddin, if you can now unmute, go ahead and go.
Hello.
Then we'll hear from you. Yes, Nuruddin.
Yeah, please, my concern is that anytime we have such presentations, we need to involve like stakeholders like NHIS business, because all these we are talking of as RDT cases. Anytime we do the testing and retest, they are to bear the cost. So some of our concerns and challenges will be channeled to them for them to respond appropriately to us.
Yes,
So,
that's a
thank
Can you add it to your evaluation comments, please? Just make it a comment on the evaluation, just to put emphasis on it. Richard Osei.
Okay. Thank you.
Richard Osei.
I'm suggesting for over the years, a lot of funds has been pushed in this malaria elimination program. Why don't national or headquarters pick a pilot district so that all the programs, be SMC, indoor residual spraying, the malaria, the new introduction of the vaccine, all those implementation programs should be geared towards one district, maybe for a year or two, so that we assess the impact of such programs. Where I'm coming from, Upper West region per se, we do the SMC and then the indoor residual. But typical farming community, probably they finish cooking around 8 o'clock p.m. Before they even go inside, they are being beaten outside. So it's making the impact of such program, the SMC and then the mosquito net, not being realistic. So I don't know if it could be looked at so that we just pick a district as a pilot. So we gear in all the programs and see how effective that one too will be.
Thank you very much. I know Jeffrey is taking notes and definitely will respond or share this information with other colleagues to make it work. So we are getting to the end of our program. We've gone 5 minutes, almost 10 minutes past 5. I can see more hands coming up, but we need to stop at a certain point. So maybe I'll give the last opportunity to the last 2 hands. But please, I think for some of the comments, it's actually been addressed. So let's hear Benedict, MB, snappy, just go straight to your question. No long preamble so that we can close on time. People have had a long day. Thank you. Yeah, Kenry, Benedict, please, be very snappy. Nuruddin, I see your hand. Is it an old hand or a new one?
It's a new one.
Just don't do a long preamble. Please just go straight to your question and then let's get the answer for that.
Okay, thank you for that. It's a concern to, again, like our programs, we always do like SMC and the rest. And it need to be fast track. Like this time that very soon we enter the peak season, and that's the same time the program will kick off. And is that those who are on anti-malaria drugs, some of them, those on anti-malaria drugs, you are not supposed to give them. So if they will be like before that time, the program has kicked off, and then those who are to take it will be able to take it as early before the season starts. Thank you.
Okay, of that. Again, the evaluation form, it makes room for such comments, which can be shared with the stakeholders. So Benedict, you are the last to be given the opportunity. Benedict Kanjiri. Okay, Benedict is not talking. Let me take this opportunity to thank everybody who has spent over 2 hours with us on this CME. The Eye Society of Ghana is very grateful to you for spending your quality 2 hours, which you could have used for other purposes. That is for those of us on the Zoom meeting, as well as for those who are on the YouTube. We are very grateful to you. So just a quick summary. Everything seems to have worked together perfectly. And as I appreciate the 4 speakers, I will start with Rosemond. Rosemond is a clinician, and most of us on the call are clinicians, and we are really the first point of call. We are to observe and identify challenges. So we realize that if the anti-malaria is not working, the patient keeps coming and going, then we must begin to speak to researchers, like the first speaker, Dr. Benjamin Abuaku, who will help us to define and tell us whether the anti-malaria ACT are efficacious. From the data he presented, the drugs are still working. So that gives assurance to the clinician that either I look elsewhere for an alternate diagnosis, or I have to really keep speaking to the researchers. For clinicians to do some research, it's very important that we get support, little funding here and there, and that is where Novartis will come in. So let's define our collaboration with researchers, including our first speaker, professor, clinicians like Dr. Kukru, Rosemond, and then also get our sponsors coming on board to define exactly what we want. Ultimately, everything is going to lead to a proper scheme for elimination of malaria. And that is where Farm Joe, Jeffrey, Aidan Aqua's presentation comes in. So all these are well dovetailed. Together, we can make effort to end or eliminate malaria in Ghana. On that note, thank you very much. Please, if you have any comment, put it in the chat box. Very important so that we can add it to the evaluation. But we thank everybody for making it. It's been a wonderful time working with you. Have a very good evening. I'll hand over to Water Society if you have any comments or announcements before we close.
Thank you very much, Dr. Animal. I think you have said everything. Kindly fill the evaluation form whilst the link is still up, and we would share the slides as and when we get them with participants via email. Thank you so much for joining us for this CME. We have another CME coming up on Friday. As we are well aware, this week is World Immunization Week, as well as Child Protection Week. So we have another CME coming up this Friday on vaccinations. So kindly stay tuned and look out for the poster and the link to join. Thank you very much and have a good evening.
Thank you all for coming.